This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube.
What I'm going to talk about today is autism subtypes. I'm a pediatrician first, obviously, medical geneticist second, and I spent really the first 75% of my career doing medical genetics, seeing children with birth defects, various genetic disorders, and seeing adults as well, because medical geneticists, we see everybody. And back in the probably late 80s, early 90s, children with autism were referred into the genetics clinic. And the question was, did they have Fragile X syndrome? There'd been some papers that had come out saying that Fragile X syndrome, most of those kids had autism, and maybe this was why we had so many more boys with autism. And so they started coming into genetics clinic. Now you have to understand that geneticists think a little bit differently than most people in the world. Genetics is a relatively new medical field, and what's happened over the last 40 years is that the number of genetic disorders has gone up 20-fold. It's not because we're all getting sicker or there are more problems out there. It's because things that we thought of as being one disorder, we've actually separated into a bunch of different disorders. So if we're a geneticist, we don't really think we're making a diagnosis unless we can tell somebody what caused the disorder. So we really think about etiology. And of course that just comes from our background, because often when people come to see us in medical genetics, certainly not all the time or not even half the time, but part of the time, they want to know what the chance is that this disorder will show up in the family again. Is this something that's going to be passed on from generation to generation? And we can't tell people that without knowing what the etiology is. So I come from a new, relatively new, it's the latest medical specialty that was admitted to the American Board of Medical Specialties. And I was fascinated with children with autism. It was like a light went on and said, this is really where I'm supposed to be and what I am supposed to be doing. Fabulous kids, fabulous families. And I would see children and they would fit this diagnosis of autism, behavioral phenotype. So there were impairments of communication, problems with social interactions, repetitive behaviors. And this is Matthew, cute little guy with autism from southern Missouri. We would go through DSM V criteria. They'd get the ADI and the ADOS, and they would fit all of these criteria. But as a geneticist, I would see somebody this week, and then I'd see somebody 2 weeks later, and I'd say, I don't think these kids have the same thing. They have a different age of onset. Some of them are much more severe than others. And so as a geneticist, I was trying to separate things out. The other thing was that there were a lot of other symptoms besides those three core symptoms. We knew that there were some children that we saw were really high functioning. Other children were lower functioning. Some children, mothers would say, from the time I brought him home from the hospital, there was something different from his brother. I could tell there was something different going on. And then there were the children who seemed to be just doing fine, and all of a sudden, about 18 months, they kind of fell off the wagon. Language faded away, social interactions changed. And from a medical standpoint, when we look at different disorders that have different causes, usually the time of onset and the type of onset signify something about the disorder. So we think of something like multiple sclerosis, usually comes on in mid-adulthood, and it comes on in about the same way. We knew that social responses were different. Some of the children, as this little guy, Gary here, was very aloof. I could sort of examine him. He didn't really care. Others were much more passive, and some were active. They were, I thought, well, this is fine. This child's coming and running and sitting on my lap. But their overtures were somewhat odd and not what you would expect. And these are Lorna Wing's subgroups that she developed back in the 80s. And we now know that kids actually can change from one to the other, so they don't stay with us forever. And then we know that a lot of the children have symptoms that if there wasn't autism there, we might say it was ADHD or ADD. Aggression can be a problem. Some children have self-injurious behaviors, and a lot of kids have problems with anxiety. And these behavioral symptoms are all very helpful for treatment planning. And so here in the Mind Center with, or the Mind Institute, having experts in many, many fields, that's a very important thing to look at all of these. And then there are a lot of medical symptoms. And so as the physician in the group, I would be seeing a lot of the children and being asked, well, he's only eating 3 different foods a day. And luckily one of them's muffins, and you'd be amazed how much you can get into a muffin. And this didn't make any sense because I'd done a lot of work with metabolic disorders where children may not eat anything with protein in it and take the hamburger off the bun because they had problems metabolizing protein. And the eating disorders we saw in children with autism just didn't really fit in with any of the metabolic things that we thought about in genetics. Sleep problems, of course, were prevalent. Some from early on. Mother and family I saw on Friday, she said, I really haven't slept through the night in the last 7 years. That's a long time for not sleeping through the night. Other children's the sleep problems sort of abate as they get older. Seizures are common. GI disorders. And we had a wonderful talk with the residents and fellows and postdocs at noon, looking at, are these GI disorders actually something separate, or is it some other part of the nervous system that's looking at that? Motor difficulties, I think, are one of the ignored problems in autism, but many of the children have real problems with riding a two-wheeler, even though you wouldn't think they would have the problems based on other gross and fine motor activities. Tone can be decreased usually. Toe walking, which is common in all kids, will toe walk a little bit, but it can sometimes be preserved for a long time. Kids with autism tend to be pretty clumsy. These are not often the kids who really do well in sports. Handwriting can be a problem. Toilet training is delayed. Toilet training, and again, having worked in genetics with lots of kids with neurodevelopmental problems, we'd always say, well, the toilet training is delayed because, there's some cognitive problems and they're just, not paying attention. But in autism, we seem to see the toilet training is more delayed based on anything that you would expect based on either motivation or certainly any medical problems we can look at. Sound sensitivity, common feature, this little guy here. And this was just in clinic, not wanting whatever the noise was outside the room to bother him. And really getting a sensory overload. I mean, I get a sensory overload when I go to the mall, but these are children where, we're very careful, and I'm sure you have here, we don't have fluorescent lights, we don't have all of those things that are humming, so we trying to decrease the sensory things that might bother kids. And this is really very helpful in treatment planning. We're part of the ATN, the Autism Treatment Network, which is a consortium of, now we're up to 14 different centers across North America. We're expanded into Canada, where we're saying, okay, we want to know what all the causes are, what the genetics is, all of the things, but we really also want to know what we can do to help kids. And so it really is an organization put together by primarily pediatricians to look at treatment. And we look at all of the medical things as well. So here we have all of the different behavioral, diagnostic core symptoms, other behavioral things. And then we realize that this is a pretty inclusive group. So if you look at children who fit the communication, social interaction, repetitive behavior core symptoms, that's a pretty big group of kids. And what we're moving to now is trying to figure out what exact causes are, and that's where being a medical geneticist comes in. That's the kind of thing that we want to do. But it's difficult. I thought, back in the 90s, we'll be able to figure this out pretty fast. I remember the director of NIH saying, well, you give me 300 families. I can find those genes for you. I don't know whether he remembers that statement. Don't tell him that. So we need to address both the symptoms and the causes. And in the best of all possible worlds, it's going to happen someday, we'll put them all together. Because we want to come up with diagnoses that are really helpful, that really mean something. So the implications of a diagnosis, and I was talking to Dr. Ozenoff today, what good is it to say PDD-NOS? Parents come in and say, I know there's developmental delay. Aren't you going to tell me something different here? So we want something that is going to help determine prognosis, so planning on education and things, what the course is. We're getting information, and we know that most children with autism progress over time, which is again, very helpful. But if we could be more specific with parents, would even be better. Which are the appropriate treatments? Which child is going to do best with speech therapy? Which child is going to do best with intensive behavioral therapy? Now, actually, we know that kids do best if they get both of those, so they're not very good examples. But are there specific children? And one of the things that we're looking at is some of the complex children who don't respond quite as well to intensive behavioral therapy. What can we do for that subgroup of children as far as therapy is concerned? And then are there other risks? Are there other things that we ought to look for? We always talk about, or think about anyway, a risk for seizures, but there are other things in life that we'd like to know about, because being prepared, we can mitigate some of those. And then, of course, recurrence risks for families that are still planning on other children, wanting to know whether this is a problem in other pregnancies, and also just the same things that we do with any other pregnancy. What can we do to make sure that this is a healthy baby? So the basic things of diet, vitamins, staying away from alcohol, cigarettes, all of those things are just as important for families of children with autism. So we now have, here we have Dr. Rogers here, who I know has probably talked to you all about this lots of times before, but the proposals for the DSM V, where we're moving all of these autistic disorders into a unifying diagnosis of autism spectrum disorder, not differentiating between autism or autistic disorder and Asperger's and PDD-NOS. And really looking at social communication as one domain, and then the fixed interests and repetitive behaviors. but estimating the severity of these, and this is going to help, and then looking at other things that may go along with it. Did this child have seizures? Did this child regress? I think of this as being a holding pattern, a very important holding pattern, as we really are changing the nosology or the classification of autism from a strictly behavioral phenotype to one that's based on etiology. Now, hopefully I'm going to be around long enough to see this come to fruition, but this is really the first step in that progression. So my question, as I started out, and this question that I'm still working on 20 years later, is, why are these children so different? So we needed a strategy. How we were going to really attack this problem, and the strategy is to see if we could come up with biologically discrete subgroups of kids. And the first step is to identify phenotypic features. Now, phenotypic features is kind of the term that a geneticist used. Psychiatrists use terms like endophenotypes for the same thing, and NIH has kind of settled the argument, and we call them biomarkers, so we use that for everything. But that can be physical features, clinical course, when the disorder started, what's the trajectory, outcome measures, genetic variables, and I'll tell you a little bit about what I mean by that, neurologic and biological variables. And there's a tremendous, I think everybody I talked to today is talking about what biomarkers can we find, what hooks can we find that help us identify what makes that child and that group of children with autism different, and also helps us predict what treatments and hopefully cures are going to work for that group of children. This is actually the easy part. The second part is if we identify something that is variable in the population but still consistent. So we're looking for something where if I see 20% of the children with autism at the Thompson Center in Missouri, let's say with generalized dysmorphology, we want to identify something that if we look at the children here at the Mine Institute, you're also going to find about 20% of the children. So something that's variable and seems to be stable in autism groups. And then we use those features to define subgroups of kids. So let's say we'll look at all the children with autism who have a relatively large head size. And we know that's a common variable that we don't really understand. But if we define the group of looking at those children with a larger head size, then we can look at them in more detail to see what else goes along with it. So do the children who have larger head sizes, are they more likely to have seizures? Well, the answer is no. We know that. Are they more likely to do one thing or another? And we have some data on that, but it's hard to get exact ideas of what we mean by larger head size. Is it larger than what we find on the graph? 2 standard deviations above the mean? Well, I can tell you my partner back at work, his head circumference is way over 2 standard deviations, and he thinks that's just great. But what about kids who they were supposed to be at the 50th percentile and they're really at the 75th? So it's hard to actually quantify some of these variables. And then once we have those subgroups, we need to look at them and see, are the outcomes different? Are the genetic indicators different? Do they respond differently to therapies? And then if that's true, this is what really proves for us if they fit all of these criteria. That gives us an indication that we're looking at a relatively homogeneous group of kids, and we should start looking for etiologies in that group. So, you can go out and you can say, okay, I'm going to do gene studies, I'm going to do a GWAS study, and I'm going to look for all the genes, or maybe I'm going to look for all the genes that are expressed in the brain. That's kind of a lot. But anyway, and see whether the children who have autism have certain ones and the children who don't have them. Well, you're going to have much better luck if you're looking at a homogeneous subgroup of the kids rather than looking at everybody together. So we've studied a lot of these, and I would keep you here all evening and going through all of them, and I just outlined the ones that we're going to talk about today. Dysmorphology, and we'll define that, facial phenotypes, pupillary light reflex changes, and family histories of related disorders. We'll touch a little bit on the relationship to the improvement with fever. We know that about 5% of children have actually a small head size, and that's a very discrete group of kids that are different than other children. About 20% have malformations that a neuroradiologist would pick up in brain formation, macrocephaly, the large head size, regression or loss of language occurs in a significant group. This is a very busy slide, and I don't want you to look at all of it, but just to give you some lists of what these variables may be. Well, we could look at social functioning, and that really is not consistently present in a portion of autism. It's present in everybody that has autism, because that's how we define it. So using social functioning as one of these variables is not very helpful. Now, that doesn't mean that we can't use subgroups of social functioning to do that. Let's see. We can look at cognitive ability, and yes, we can really define whether we're defining it here or whether we're defining it in Missouri or wherever. We see probably about the same variation in different groups of kids. It's not terribly discrete. Yes, we can measure it. Is it constant over time? Well, mainly, but not always. We know that it's really hard to test kids with autism, though the people here are really good at it. Is it pathophysiologically relevant? Yes. Does it suggest a genetic marker? Well, maybe, but it's really hard to look at. We can look at clinical course. So the age of onset is actually interesting. We've got yeses going all the way across there. Having regression, having that falling off the wagon type thing is also interesting. We've got yeses going along there. We know that some adolescents develop this catatonic regression, and it's a subgroup of kids. They're kind of hard to study because we don't usually see it until they're teenagers. And then we've got some that I've outlined in yellow that we've looked at. So they're all the medical variables. Seizures are a really mixed bag because seizures are just as heterogeneous as autism is, so that's been difficult. EEG abnormalities are particularly hard because they're so variable, and if you do an EEG for 24 hours, you're going to find something different than if you do an EEG for 20 minutes. Sleep disorder, we're going to look at PLR parameters. We've got mostly yeses in there. Dysmorphology, family histories of specific disorders, so autism. Some families have family histories of autism in lots of different generations in the family. Alcoholism, ADHD, bipolar disorder are also on the list. This is also Matthew, and Matthew is just a really neat guy from Northeast Missouri, and if you ran into him in Walmart, he'd just think he's a cute kid. But he's got some features that really don't look like his brother or his mom or his dad. He's got this really pronounced Dennis the Menace upsweep of his hair. Now, the glasses are sort of dating, but I think he liked those. His teeth just sort of look like somebody kind of threw them in there and they didn't quite go, but, lots of people have that. I remember all the braces I had for years. But his jawline is different than what you're seeing in his family. And if you looked at other things, you could see that his nails were different than, again, what you see in the family. And this is what we call generalized dysmorphology. So it's not one thing that's different. I do dysmorphology with the medical students and the nursing students, and we go around the room, and I don't let them leave until they find something that's outside 2 standard deviations on themselves. So I show them my single palmar crease. I ordered that just for teaching purposes. And so we all have, some of these little things. What we're looking at, though, is kids where it's generalized. There are enough things going on that we can use the premise that these children had some insult to embryologic development. And that's going to suggest that they're going to be genetically different. Now, it could mean there was an environmental factor that affected them early on, but generally we're talking about something genetically different. And so our goal then is to pick out kids who, by looking at dysmorphology, that we can pick out as kids who probably had some insult to early embryogenesis. And when we do that, we find, and this just is one cohort that we've published of 260 children that we saw consecutively. And what we found was 15% of those had this generalized dysmorphology. And when we looked at these kids, they really were, had different characteristics than the children who were not dysmorphic, just meaning their morphology was different. One was that they were much more apt to have microcephaly. Remember, I said that was really a pretty specific group. So we see some children with small head sizes that are fine, but it's a pretty specific indicator that something has gone awry in brain development. So 18% of those children with dysmorphology also were microcephalic. 43% had a brain abnormality that would be picked up by a neuroradiologist reading a MRI scan. 36% had seizures, where only half that number had seizures in the non-dysmorphic group, but not nearly as many had regression at onset. Now, this is regression based on family report, so we're talking really the falling off the water or off the wagon regression, not just maybe going down a little bit. So it's a little bit different depending on how you define it. We'd like to know outcome. Well, when you're looking at kids who are anywhere between the ages of 4 and 17, it's hard to say you know outcome. So we use here IQ measures just as a indicator of that. And the children with generalized dysmorphology were only half as likely to have an IQ over 70. So only 22% had an IQ over 70, whereas 43% of the other children did. 52% had an IQ that was less than 55, more than the children who were not dysmorphic. But we want to know about genetics. We want to know whether is this biologically relevant. Well, do we draw blood and start doing gene finding studies on all these kids? It's a little premature to do that with this kind of subgroup. But we can get some indicators, and one of the indicators is the gender ratio. So we all say, 4-to-1 males to females with autism. And one thing we know about is male versus female, that's definitely genetic. And what we find is that the children with generalized dysmorphology have a more unified or unity-based male to female ratio, and this in different populations we've looked at has been anything from 1.8 to 1 to 3.2 to 1. So it's not 100%. It doesn't mean that it's the same number of boys and girls, but it certainly goes down that way. The children who are not dysmorphic, anywhere from 6.5 to 8 to 1 males to females. And this goes up as the population that you're looking at changes. The SIB recurrence risk. So is this something that's going to happen again? Well, it's not 100% if it happens again that it has a genetic etiology, but it's certainly much higher. And in this population that we studied we reported pretty early on, when we looked at the SIB recurrence risk for the non-dysmorphic, it was 4%, and this is 4% for autistic disorder, with no broad autism phenotype here. And the SIB recurrence risk here, and of course we're just looking at 39 kids, was 0. And we've repeated this as the kids have gotten older and it has reached significance. And this is obviously an aberration because in this group of children with dysmorphology, there's some syndromes that have a recurrence risk to them. But overall, if you're looking to try to figure out the recurrence risk of general autism, it's better to just look at the non-dysmorphic kids or look at them separately from those with dysmorphology. And then the other important thing from a clinical standpoint is we were spending all of this money. We were doing EEGs and MRIs and chromosomes and now microarrays on all the kids we were seeing. We were doing metabolic studies on all of these kids. And that's why I'm kind of using this cohort, because this was really the mega worked up group of kids. And they all were evaluated carefully by genetics. 26% of these kids, we could make an etiologic diagnosis. So this is where the money was as far as looking and spending. You know, we don't want to put people in the poorhouse if there's a very low chance of finding something. And we didn't come up with an underlying etiology for any of these children. Now, this is pre-microarray data, so we do believe in doing microarrays on everybody. But it told us something about boys versus girls. I was telling the graduate students and fellows today, going to a women's college, you get to be a bit of a feminist. And when I got into autism, and they said, the girls, they just don't do as well as the boys, and yada, yada. So I said, well, Temple Grandin, she seems to be doing pretty well. And I looked at the bookshelves, and all these women with autism had written books, and I thought, well, that's not too shabby. And so we were looking at the boys versus the girls with autism. And this just happens to be a group that we had studied. We had 214 consecutive children. So when we, into our research cohort, we don't have any exclusions, and it's everybody that comes across the door and everybody gets asked to participate. So we had 214 consecutive children. Male to female ratio of 4.9 to 1, no difference. They all had CARS scores and their age and the SES, and then the regular diagnostic measures were the same. Mean age of 9.1. And we looked at IQ scores, and we looked first at what the IQ was, and it really wasn't much different. So I thought, well, this is good. I'm in there rooting for the girls. So 65.2 and plus or minus 24.7, really interesting range. Boys didn't really look much different at all. So, looking at this, you'd say, well, this doesn't really look much different. But when we looked at a distribution, it really was different. So we had a distribution of boys that kind of looked like that normal curve, not exact, but kind of just pushed down some. The girls, however, really is somewhat suggestive of a more bimodal distribution. It's not your normal curve. And lo and behold, when we looked at girls versus boys for the features that we were looking at to define this complex autism phenotype, dysmorphology being the main one, what we found is the girls were much more likely to have generalized dysmorphology. So 25% of the girls in this cohort, when we did this full dysmorphology exam, fit the generalized dysmorphology, but only 9% of the boys. 11% of the girls had a head circumference less than the third percentile, only 5% of the boys. Brain abnormalities, we sort of dropped that out of complex autism because it wasn't terribly helpful and it wasn't very precise, but it's still a little bit higher. So putting this together, complex autism was what we defined as children who something was going on that was more complicated than what we think of as sort of the garden variety of autism, the common autism that people think about most. And what we found was that this complex phenotype fit 44% of the girls and only 25% of the boys. So it wasn't too surprising that you had girls that had a different range of outcomes versus boys. And it was also told us that we needed, when we did other studies, to separate the kids with essential autism, which is really the remainder, from the kids with complex autism. Because when we mushed them together, we were just getting, things that we couldn't interpret. This just happens to be looking at ADI-R scores. And what we showed is in the composite scores, though they weren't statistically significant, the girls really had better scores than the boys. Here, lower scores are better. And the girls only had 8 items where the girls didn't do as well. But the boys had 26 items where they didn't do as well. And these are just some of the items where the girls excelled in the boys. But if you put the complex kids, and I have another slide with that I didn't bring with me, but if you put the complex kids in this same mix, you're not going to see this. It's just going to get covered up by the data, or by the. And then we want to know about recurrence risks. Again, being a geneticist, that's kind of one of the ways we think of the world. So I thought, well, there's information in the literature that says, if girls have, if it's a girl, they're going to have a higher risk of having a next child with autism. So we looked at siblings of girls and boys with autism. And we looked at girls, and we only had 52 girls in this cohort. And sure enough, 4% of them had true autism or autistic disorder, or a SIB. And we had 193 boys with latter SIBs, and 4% of those had true autistic disorder. And these, for lots of different technical reasons, we were just looking at the autism kids. So that didn't tell us anything very much at all. But it didn't look like it was related to the sex of the initial child. But when we broke it down to the gender of the next child in the family, the girls' SIBs, their brothers, it was an 8% risk, and in this just group, none of the sisters were affected. In the boys, it was 6%, in their brothers, 1% in the boys, and then in the total. So it really depended on the gender of the child, not the gender of the initial SIB or proband. So there was a significantly higher risk for boys, whether that first child was a boy or a girl. And what that tells us is that essential autism doesn't fit the standard threshold model. And we use that for things like pyloric stenosis and cleft lip and palate, and one of those things before you break out all the different genes that are causing something, and you've got groupings of lots of things together. Because what that says is the most frequent sex has the lowest recurrence risk. But that wasn't true here. Essential autism, and again, this is just looking at essential autism, boys and girls SIBs have the same risk. And that threshold model also says that the least frequent sex is the most severely affected. So that would be, or the most severely affected, so that would be girls. And what we were able to show is, no, the girls actually with essential autism were less affected than the boys were. Well, this is all just sort of giving us clues as to what to do next. And this doesn't really say that there aren't a lot of things going into forming autism, but it does say that girls and boys are different. And I like this. We have a saying, don't know whether it's okay to say this, that we're all on the spectrum someplace. It's just our husband's a little bit more than we are. So I have lots of friends who are psychiatrists who said, well, this is all very well and good, but you're a geneticist, and we can't get our kids in to see the geneticist for, 8 months, and, it's not worth our time. So is there a way we can identify this? And I'm just going to zip through this quickly. But so we developed a measure to look at dysmorphology for non-geneticists, looking for features that infer there's some altered morphogenesis. But it was much more difficult than I thought it was going to be. Went up to see Kathy Lord to say, how do I make this? And she gave me advice and all those things. And it still didn't get much easier. And geneticists look at one little thing. So we look at the ear and we say, that crus is right there. Or we say, the antihelix is a little bit bigger or things. Well, nobody in their right mind other than geneticists are going to look at all of those things. So what we did is we looked more at things, parts of the body. So we looked at fingers and I can't even actually see what that is, face and feet and teeth and upper limbs and all of these things, and said in the group of kids, and this was 300 children with autism that we had looked at very carefully, and from a genetic standpoint said this group has generalized dysmorphology, this group doesn't. And so it's the group in yellow that have generalized dysmorphology. So in that group, they were much more likely to have something on the hands and fingers that was different than what you would see generally, but most important, it was different than their parents. Because I have my husband's, or not my husband's, my father's feet. And when our son was born, the first thing he said is, "Oh dear, he has your feet." And they're probably well outside 2 standard deviations. I was the kid that you walked on the cement after it rained and you couldn't see there was a connection between the front and the back part of the foot. But they're family feet. And so you don't have to know what a foot looks like a great deal, or you don't have to know how a geneticist says, this is a so-and-so, hallux valgus or something, but you do need to look at the parents. Of course, it helps to have some idea of general stuff. But we'd say with fingers, do they look like the parents? Is there a tapering that's different? Is there an incurving in the fingers that are different? And we'd look at the feet the same way. Hair growth patterns. Is there a normal whirl off to one side? Is the hairline normal? And what we found was that we could identify for just about everything, the children with generalized dysmorphology were more likely to be graded dysmorphic for all of these features. So we thought, well, we'll use these. We won't use just the genetic things. It doesn't hold for everything. So head circumference, for instance, children with a large head circumference were much more likely to be in the group that were non-dysmorphic. Joint laxity is about equal. Deep set eyes is about equal. We put together a measure and an algorithm, and you only have to look at 12 different things. So it's much more usable, or at least user-friendly, than going to the geneticist. But it's really used as a way of sort of getting a first pass. And here's just an example of a family, mom, dad, sister, and son with autism, who, cute little guy, but we can see, his hair growth pattern is different than his sister and his mother and father. His eyebrows are a little bit different, his teeth are a little bit different. And that's kind of how we put all this together. So the utility then is, in research, is when we're looking at large groups of kids and trying to make sense out of it, it helps to classify kids by different etiologic energies or indicators to decrease the heterogeneity. And it's going to increase the power of the analysis and allows for a more targeted search. And of course, in this day when money's always tight, if you're going to do a study, it really helps to pinpoint the group that you want to do it in. Clinically, it helps with prognosis. Education-wise, it's something that's been useful to teach dysmorphology to non-geneticists, but also to medical students and residents and fellows. Because it has less of a dependence on expert clinical judgment, and it can be done in a closed exam. So, it's really nice when we've got kids in autism that really don't want us with autism in clinic who they've been through a long day and they don't really want to be sitting up on the table and having to take all their clothes off. So this is done by inspection. So that's kind of the first pass, was to say some of these kids are more complicated. We need to look at them separately. We actually, for a while, just kind of ignored those kids because we were trying to look at the kids with essential autism, thinking this is where we would learn a lot. But we now have a grant where we're looking at these children with a complex autism to see what we'll learn there. Looking at kids with essential autism, and again as a geneticist, I was impressed that there is an autism face. Going back to Kanner, the beautiful child with autism. Well, what makes somebody a beautiful child? One of the things is a relatively wide face, relatively open face, eyes large, relatively wide set. To look at models, that's the face that they have. Those of us that have to push the microscope objectives together, not good. And so what I saw were these kids, really cute kids, but this really engaging, slightly wide set eyes. And what really capped this for me was when I got, this is actually a Thanksgiving card from a family from Missouri. And these little guys are brothers. They're about 11 months apart. One has autism and one doesn't. And I don't know whether you can see it, but one of them sort of has the face and the other one doesn't. So I thought, I've got to figure this out. It was just sort of one of those things. And the reason I'm telling you this is there really is a tremendous advantage to being in clinic, to learn something from all the kids that come in. I can assure you that what I've learned about autism, though I learned a lot from everybody here today, has been in clinic, not as much from books. So we looked at all these things, and I went to Dr. Aldridge, who is a neuroanatomist and anthropologist, to see if she could help me with defining that look. And using the three-dimensional camera, we're able to capture the image, and she's able to mark each of these little landmarks done on the pictures, not on the kids. And we calculate the linear distances, the proportions, and the angles of all of those. We do this with a 3D system, so we have usually a more comfortable chair that's just set up for a baby, but 4 different cameras set in the corners of the room, so there's 16 different cameras actually that are going off at the same time. And then you get this picture in the computer screen that you can turn, and you can look at the side, and you can line up the parents and the siblings, and you can turn them all together and say, is that really Dad's nose, or is it the ears the same? And then what Dr. Aldridge did, this is a paper that just came out, where we looked at boys between the ages of 8 and 12, all with essential autism, which we thought was very important. Old enough that brain and face were pretty mature, but young enough that puberty hadn't changed anything. And we looked at all these anthropometric landmarks and did statistical comparisons. The first thing that we did was to really look for differences between the group of children, the 71 children with autism, and the controlled children. And this, again, is Dr. Aldridge's work. She's the statistics guru. But really what we're doing is testing for significant differences for each of those distances. And what we found in the children with autism, that the orbits were wider. The nasal bridge was actually narrower. Where I was thinking I was seeing a wider nasal bridge, it actually was narrower, but the eye sockets, the eyes themselves were bigger, which of course is very attractive. A wider mouth. The philtrum was actually shorter and wider. So the lines in purple are the measurements that were shorter statistically in the children with autism, and the white lines were the ones that were larger in the children with autism. So that looked interesting, and it was, yes, it's sort of what I think I'm seeing, but I'm not absolutely sure. But you know, the observation is really what gets you in the door and gets you interested in looking at things. So the next thing that we did was to do a principal coordinate analysis, which is a clustering technique, looking at the different axes with the children with autism, their measurements in red, and the typically developing kids in blue. And here we see that we found two different subgroups, and just put them both on there. In this subgroup, subgroup 1, which is about 17% of the kids, there really was a different group, and this is this group out here. These areas were shorter, and then this jaw area was a little bit longer. But in this group here, we had these facial measurements were longer, and then these philtrum mouth measurements were shorter. Well, that's kind of interesting, and I've never been a great fan of cluster analysis because anything you cluster, you can come up with subgroups for. Maybe it's I just don't understand the statistics well enough. But anyway, I thought, well, that's kind of good. But does it mean anything? You know, you can say some people have blue eyes, some people have brown eyes. But if it doesn't mean anything, there's nothing to do about it. So we looked at these kids to see whether there actually was some difference. And in fact, we did see differences. So the children, when we looked at autism features, they're more likely to have a diagnosis of autistic disorder. And their SCQ scores were higher. They were more likely to have had regression. Their full-scale IQ was less, and their nonverbal IQ was also less. On this group here, though, they were much more likely to have an Asperger's diagnosis. This was only 7.8% of the group. Their SCQ scores were less. Their IQs were higher, and they developed language earlier. Their general language tests were not, didn't distinguish them, but their time of onset of language. Macrocephaly, and I was trying to remember this today and didn't have the slides with me. This group was much more likely to have larger head circumference greater than 2 standard deviations, where this group was less likely. This group was more apt to have seizures. This group was more apt to have GI problems. Feeding infant problems, I have no idea exactly what that means. Less likely to have infant feeding problems, more likely here. And I don't know whether we're looking at more of a autonomic problem there. Well, from Dr. Aldridge's standpoint, she's interested in the embryologic pattern. And so these are really perturbations of the frontal nasal process and the mandibular prominences. This is more just a frontal nasal process. And we're able to, just from the literature, know that things that affect these, here we have sonic hedgehog, BMP4 and some other genes that we can look at. Looking up into the Wnt pathway is also something that affects how the face develops. So this is an avenue to go into to look at that. So we're sort of at this point in this project. We're looking at the face and say, yeah, we think we've got some groups that are meaningful. We can always get groups, but do they actually mean something? Are they biologically significant? Are they genetically significant? And so we've sort of gotten to here where we can kind of look at the embryology. And so Dr. Dewan is looking at, are we seeing face-brain coordination with these? And we're continuing to look at phenotypic differences as well. So that's kind of, again, more of that physical morphology, what the geneticist comes from. It's kind of fun to move from one area to another. And I think that's one of the great strengths of here at the Mind Institute. There are people from so many different disciplines that, I was just amazed at lunch today, all of the information from so many different specialties all coming together. Well, this is a different study, but again, looking for biomarkers, looking for something that's going to describe what's going on with autism in addition to the behavioral. It's not substituting for the behavioral measures. And this is Dr. Gary Yao. He's a biomedical engineer. Really amazing, bright guy. And he works on optics and light and physics and things. And he developed a way of looking at the pupillary light reflex. And the pupillary light reflex is that very simple reflex where you shine a light in the eye and the pupil gets smaller when you shine the light in the eye. And I thought, this is fine. I learned about this in about 10 minutes in medical school and it didn't seem very exciting to me. Well, I had a lot to learn. And this change in light is controlled by the sphincter muscles. There's the sphincter muscle and the dilator muscles of the eye. And it's controlled by the autonomic nervous system. And this is just a copy or a picture of the instrument that he developed. And this is much more sensitive than the instruments that are out there. So we're looking at, just a few milliseconds differences. And looking at this pupillary light reflex, and I'll walk you through that. This is the size of the pupil, and the initial size of the pupil here. And this is time, and this is measured in milliseconds. So there's a period where you're just measuring the size of the pupil, and then you shine the light, and then there's a period of latency, a time when the pupil doesn't change. And then all of a sudden it constricts and gets smaller, then redilates and goes back up. And we can look at latency, we can look at the constriction time, we can look at the constriction amplitude, and all of these as components of this neurologic pathway. And the reason that this is exciting to work with is that it's simple. Where I thought, this is simple, this may not be exciting. Exactly the reverse is true, because if you're looking at the entire brain, you're looking at something that's very, very complicated. So this is a relatively simple, well understood pathway, and that's really the beauty. You shine the light in the eye, hits the retina, and goes down through the optic chiasma, down to the pretectal nucleus here, up to the EW nucleus, over here, back to this eye, and this just shows it's going back to both, and you get the eye constricting. So it has to go through this pathway, but compared to looking at the whole brain, it's a simple pathway, and simple means we might be able to get some sort of handle on it. This is Dr. Fawn, who was the first author on the first paper of this. This is actually data that is just about ready to be sent off for publication, where we're looking at 152 kids with autism, and males and females, all the different diagnoses, 107 kids who are typically developing and 36 kids with neurodevelopmental disorders. On all of these kids, they go through the same phenotyping protocol as well. And what we found, and I'll just go through just a little bit of this, don't do it justice compared to Dr. Yao, but these are the stimulus conditions. So it's looking at children who have been sitting in the light, so that's light adapted, and this is just the intensity of the light, light adapted and dark adapted. And in each of these, what we see is that latency period in children who don't have autism is a lot shorter than the latency period in the children with autism. And we see that in all of the different stimulus conditions. And looking at this latency, what we see here is it's very significantly different in the groups. And we're able to distinguish the groups with 83% accuracy just looking at latency alone. We're just beginning to look at what this means from a clinical standpoint, and I'm just going to give you one example of sort of what we're looking at. One of the correlations that's turned out to be interesting is here we have the control, typically developing children, the children with autism. And when we look at the children who are toe walkers, kids who have, and this is neurologically based, so we're interested in that, but kids who just seem to be up on their toes for a long, long time. And certainly I've seen some adults who say, I'm still up on my toes. What we find is that children who were not prolonged toe walkers, their latency is more similar to the control group, where the children who were toe walkers is even higher than the regular group. So it looks like there's something else added into that group of kids. So there's something else neurologically that we're measuring that we can get a handle on, and the latency seems to go up with that. We have some indication that that's true for a lot of other indications like seizures and other indicators of neurologic dysfunction, and we're actually finding that latency is elevated in some of the kids with neurodevelopmental disorders that are not autism as well. Constriction amplitude is the other one I'm going to show you because it gets us down a path. When we look at constriction amplitude, and again, these are the stimulus conditions, the children with autism, their constriction amplitude is less, so they just don't make that pupil get quite as small. And that's consistent across stimulus conditions. The constriction amplitude is less in the group of children with autism. But we're interested in that because this is really under autonomic nervous system control. And it gets to the question of, is autism a neurologic disorder, a neurodevelopmental disorder by itself, or is it a multi-system disorder? So when we look at GI problems, we look at, GI problems is a good example. Is there something wrong in the GI tract, or is that the neurologic control of GI function? The amplitude is smaller, and so this indicates or is consistent with lower parasympathetic tone in children with autism. And so when we see this, we thought, well, we've got to look at other markers of autonomic dysfunction. So we started looking at kids, looking at all the heart rate variables. And lo and behold, it exactly mimics the same thing. Heart rate is easy to do, but it's not a very good marker because it's so complicated. We've got so many other things affecting your heart rate that just using that as a marker for autonomic function it's nice, but it's not the best. It's not terribly specific, I guess is the word. One of the interesting things with constriction amplitude that I've been interested in are the group of kids who seem to improve with their autism symptoms when they have a fever. And when we set up our initial data set, what we did was, what I did, it was just sort of fun, is I went through every question I thought I wanted to know about. And one of the questions was, what is this fever question? It was just actually a little bit in the literature back in the 90s. So we ask a question, does your child seem to have fewer autism-type symptoms when they have a fever? And so it's not a very exact question initially, but we found that actually 30% of families endorsed, yes, the autism symptoms, communication, socialization are better with fever. And so here we have the control group looking at constriction amplitude, the autism group with a lower constriction amplitude. And the children who improved with fever, their constriction amplitude was actually closer to or even above the control group, where the children who did not improve with fever had a constriction amplitude that was even less. So we thought, that's kind of interesting. And I knew about the, this just is what we talked about before, about 35% of the children improving with fever. So we knew that fever improvement really aggregated with autonomic nervous system factors. Children who improve with fever are more likely to report having their pupils dilate when they're angry, higher pain tolerance, they're more hypersensitive to loud noises, their neurologic and behavioral differences. So we're looking for mechanisms, and constriction amplitude is parasympathetically controlled. And Dr. Mailer and Perper had come up with this proposal that this was modulated through the locus ceruleus through a neurologic noradrenergic symptom. And what they postulated was the fever improvers have a defect in this pathway, decreases their sympathetic tone, and increases their parasympathetic tone. So it's possible that, and we would expect, if this is correct, that the fever improvers would have a larger constriction amplitude. So it's not proof, but it sort of goes into making the case that we really need to look at autonomic dysfunction in more detail. And that's really what we're doing now, is looking with the autonomic nervous system physiologists. And one of the problems with the initial instrument is it's sometimes hard to get children who don't like something right in their face to sit up and put their face on their chin on the little thing. So this is a system that Dr. Yao's developed that's remote, where the child can just sit on mom's lap, look at the little figures up above the system, and it locks onto the eye and follows the eye, and you don't have to get in somebody's face to get it done. And so we're hoping to really get the same results with very young children. We'll go on to that. And the last one, just to finish, is family history. And again, I'm a geneticist, and that's what geneticists do. So sometimes we forget that family history can be terribly important in giving us information. And sometimes we just ask about, mom and dad, where there's really a rich amount of information in the family. And we ask about everything in the family, everything from hypertension and heart disease and Alzheimer's, but we're looking a lot at neurologic disorders and family history. And what we find is that in family histories, this is just across the board, children with autism, 19% have a significant family history of autism. And that means either a first-degree relative, a second-degree relative with two other relatives in the same branch, so it looks like it's inherited down a branch of the family, or a third-degree relative and four other people in the same branch of the family. And so if you take a very careful family history, you find that autism is there and is often missed and said, well, that's just a long way out in the family. Alcoholism was a real surprise. Turns out alcoholism is a disorder that is easy to track in family histories, and there's been papers and studies done on this. People may not know about depressive disorders in the family, so we don't really know who has a history of depression as much. But alcoholism is something that when you're getting a family history from parents, they generally know about brothers and sisters, and so it's easier to track. Cognitive disorders, I'm not quite sure about this one. Language disorders, I think that's probably true. And ADHD, hard to say whether that's much more in the than in the general population. But alcoholism is interesting because it couldn't be more different than autism. I mean, it's age of onset, totally different. Life course, totally different. Very common in the population. The lifetime prevalence is greater than 12% for alcohol dependence. Definite genetic predisposition, strong environmental factors. Age of onset, though, is very different. We think of it as a neuropsychiatric disorder, not neurodevelopmental. So it's really just really different. So it's kind of surprising where that jumped out at us. And this is a pedigree. I should probably use one that's a little less laden. But here is this northwest corner is alcoholism in the family. And so here we have dad was an alcoholic, his brother, his father, another brother out here. In this side of the family, and then on mother's side of the family, we've got 1, 2, 3, 4 people here in this side of the family. So they would code this family as significant for alcoholism. And when we look at these families, what we found was that it wasn't a bell-shaped curve. There wasn't high alcoholism down here and really low in here, and then most people in the middle. We had 2 discrete groups of the low alcoholism and the high alcoholism families. And so we could look at them. So the children who came from these families that had significant alcoholism were different than the others. So this is the low alcoholism families and the high alcoholism families. Macrocephaly was much higher in the low alcoholism families, which was particularly interesting. And this is just defining macrocephaly as 97th% head circumference or greater. The regressive onset wasn't quite as significant, but more common in the high alcoholism families. The interesting thing is in those families, there was a high history or a high prevalence of women with alcoholism. We know that that's something we see in alcoholism, but 15.9% of the family members in those high alcoholism families of the women were alcoholics. Where in the low alcoholism families, it was just 0.9%. And affective disorders seem to go in that, though it's harder to get that kind of history from a family history. So these things sort of went together and said, it sounds like it's making sense anyway. So why do we care? Because there's absolutely no evidence that children with autism develop alcoholism. I've talked to all the adult specialists that I know around the country, and they actually don't think alcoholism is as high a risk in individuals with high-functioning autism as it is in the general population. So why do we care? Well, we care because if there is a genetic overlap, then those families that have both disorders in the family may be genetically a more homogeneous subgroup, and we can use familial alcoholism as a biomarker and look for genes that are associated with both disorders. And we know that there are not very many, but there are some genes that have been indicated in both alcoholism and autism. And these are just a few of these, and I won't go through all of these. But ones that we're all very familiar with, Norexin, the contactin associated protein like 2, which I can never say that whole name, contactin and the serotonin and the GABA genes. So I think it's an area to look at, and we have some work going on in that area. Okay. So where does this lead us? What are we going to do with this? We know autism is a spectrum of disorder, so just leaving you with that is not terribly helpful. And we can make a diagnosis with a good evaluation of 15 to 25% of kids now that we're using microarrays, looking at single gene disorders, chromosome disorders, copy number variants due to fetal exposures. And so a lot of these kids are what we're looking at in the NIH grant, that we're looking at these complex kids, and a lot of these are the complex kids. But we also want to look for valid subgroups that are based on sound pathophysiologic differences, so we can figure out what the outcomes are, what treatments work. So we've done some treatment studies looking at intensive behavioral therapy and found that in the children with complex autism, and it was a one-year study of intensive intervention. The children with complex autism did not progress. So the children, the highest indicator of whether a child who was nonverbal at the beginning was going to develop language was whether they had complex versus essential autism. And this really compares with what we knew about mental retardation way before my time, back in the 50s, or cerebral palsy, what we knew back in the 70s. These were disorders that were grouped in together. And so people, if you go back and you read some of the old papers on mental retardation, they're weird, actually, where they give you recurrence risk based on family members with just a diagnosis of mental retardation. And now we think, that's just silly. That's just a whole bunch of things mushed in together. But I remember, shouldn't tell you this, when we got our first CT scan at the university. We were waiting with bated breath. We had a big cerebral palsy clinic. Cerebral palsy diagnosed behaviorally, looking at the reflexes, looking at the tone, and then finally that CT scan hit the door. And all of a sudden, that was kind of the impetus. There were other things that went along with it. All those kids became objects of great interest, and they were diagnosed. So there were children with poor encephalic cysts. We all used to say, oh, that was birth injury. That was sort of the party line. And we found out that that wasn't true, and we could actually put together new advances in science. And that's why these new advances are so important. So using the microarrays now, it's taking new things as they come along and new studies, putting that together and looking at these children, we're able to say, that's not one disorder, it's a number of disorders. And it's just the same way as if you thought all kidney disorders were the same thing and you treated everybody the same way. Well, they wouldn't all get better. So you know the kidney doctor is going to say, no, this is this kind of kidney disease, this needs this treatment, this needs that treatment, and this needs that treatment. So if we can be more specific with pathologic or pathophysiologic differences, autonomic nervous system being a wonderful example. So our autonomic nervous system colleague, he's an expert on treating sympathetic overload, which they treat in adults a lot, thinking of heart disease and things. So we have some treatments out there, and if we can figure out things that we might be able to use that are out there and being developed all the time, we hope that we'll be able to really make great progress. And that's really here where medical investigations and having this whole group of people that are really up on everything in all of the different fields is what's going to make things go forward. And just to say thank you to all of you, and name some of my collaborators here, Dr. Yao, the person with the Pupillary light reflex, Dr. Aldridge, Dr. Fidel in physiology, my colleagues, Dr. Beversdorf, who some of you know, and the Thompson Center, and most of all the families that have just been wonderful in saying, you want blood? Should I bring in the rest of the family? Do you want me to come back next week? And really just drive and help us get all of that done. And of course, the people who come through with money and help keep it all going. But thank you so much. I really appreciate being here, and I'll be glad to answer any questions that you have or I may be able to answer.
I was interested, early on you were talking about in the dysmorphic groups, or you're talking about girls having more dysmorphology and so forth. And you mentioned brain abnormalities, and I was wondering what you were using to define brain abnormalities, which was one of your items on your list of phenotypic subsets.
That's just gross brain abnormalities. So that was defined as abnormalities that would be picked up by a trained neuroradiologist looking at a static MRI scan, not fancy measurements. So we're looking at cysts, we're looking at agenesis of the corpus callosum. Actually, the biggest group were cerebellar and position. We don't really do that much anymore. That was kind of early looking at things because it doesn't tell us a lot of information. Certainly the child with autism who has a large posterior porencephalic cyst is going to, be important. And I think one of the things that also we look at these little tiny features to indicate abnormal morphogenesis is because most children with autism don't have birth defects. They're not, if you see something major, yes, that's going to mean something. But this is really designed to look at children who most people seeing them in clinic are not going to pick up anything.
Thank you for a great talk. Yeah, very wide-ranging. I would totally agree with Irva. This is a question about your fever data. Were they the groups of kids who improve versus do not improve with fever matched on their symptom severity? Because I know Mark Mailer and Dominic have this idea. It's very intriguing, but I could also imagine the reporting bias of parents whose kids are very low functioning. What is it that is improving in particular? So how specific is this issue?
The initial data we had is really pretty rough. And we have developed a new measure kind of looking at all of that. And I know that actually a good friend of mine doesn't think that this exists. A good neurologist, pediatrician friend who should go unnamed, but I just say to her, you haven't talked to some of these families, and when this occurs, it's very much, we're not looking at the kids who is a little bit lethargic so they don't hit their sister because they don't really feel like it. We're looking at kids who really start to talk when they have a fever. Kids who are much more social. They'll cuddle, they'll climb up on their lap, they'll really be, you just want to figure this out when you have parents that come in and say, it's like the autism goes away. I don't think it's anywhere near that 35%. The data that we have now is not terribly well matched towards autism severity. It does cover the range, though it is the more severe group that reports it more often. The data that we're collecting right now hopefully will answer that question. But I think it's a very important thing to match that.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.